It's not exactly news that American families are burdened with high healthcare costs. In the United States, one of the wealthiest countries in the world, healthcare prices are often prohibitive, expensive enough that many people, especially the uninsured, put off or forgo needed care. According to the Kaiser Family Foundation in 2024, 6 in 10 uninsured adults say they went without needed care because of the cost. There are a lot of factors driving the rise in healthcare expenses. The opacity of hospital pricing is one of them, according to experts from our Center for Health Policy. Last year, Derek Jenkins, Sasathorn, Tapaneeyakul, and Vivian Ho published a report examining whether hospital price increases were really necessary to cover higher operating costs, as many hospitals claimed amid labor shortages following the COVID-19 pandemic, or if they were instead intended to generate higher profits, and they found the latter. So what have policymakers done about this? Back in 2019, President Trump signed an executive order telling hospitals and insurers to post prices online in an effort to make it easier for consumers to shop around. That led to the Hospital Price Transparency Rule, which went into effect in 2021, but compliance has been disappointing, even with another executive order from President Biden in 2021 aimed at tightening enforcement. In late February of this year, President Trump signed another hospital price transparency order, this one telling federal agencies to come up with a better enforcement strategy. Will this finally be the magic bullet that gets hospitals to disclose their prices up front and help bring healthcare costs down? Today, I'm joined by Vivian Ho, co-author of the 2024 Baker Institute report I mentioned, and co-author of a newly published report on price transparency among hospitals in Houston's Texas Medical Center, the largest medical complex in the world. She's the Baker Institute Chair in Health Economics, as well as professor at Rice University and Baylor College of Medicine, whose research focuses on the effects of economic incentives and regulations on the quality and costs of healthcare. She was elected as a member of the National Academy of Medicine in 2020. I'm David Satterfield, director of Rice University's Baker Institute for Public Policy in Houston, Texas, and this is Baker Briefing. Vivian, welcome to the show. Let's start with trends in healthcare costs in the U.S. Big picture, what does the latest data tell us?
Well, it's a pleasure to be with you here today, David. So healthcare spending, we actually reached in 2023, that's the last year for which we have complete data. Healthcare spending reached $4.9 trillion in the United States. That's 17.6% of gross domestic product. It's slightly under $15,000 per person. And that's actually an increase of 7.5% from 2022. And those increases occurred for both public insurance, Medicare and Medicaid, and for commercial insurance, which people get either through their employer or many of them through the Obamacare exchanges, the Affordable Care Act. And these increases incurred for everything, hospitals, physicians, prescription drugs. So that's maybe disconcerting, but on the bright side, 92.5% of Americans have coverage. They have health insurance. So this part of this increase is due to increases in coverage. Part of that because we still have very high Medicaid enrollment under the Affordable Care Act, the Medicaid expansion, and also because of additional subsidies to the ACA under the Inflation Reduction Act.
Vivian, I just want to clarify, amongst the factors responsible for that significant increase over 1 year, the effect or impact of COVID-19 was not a significant factor.
That's correct. When we're talking about 2022 to 2023, COVID-19, it does have an impact, but it is not one of the major factors explaining this increase that occurred most recently.
All right. In your new paper, you and your co-authors write that hospital prices are a big factor in the rise of overall health costs. How exactly do they factor in, and what's driving specifically that rise in hospital prices?
So let me first talk about what's driving that increase in prices. It's primarily consolidation in the healthcare sector, consolidation of all sorts. But let's just take hospital mergers. If you look at hospital mergers from 1998 to 2017, there were about 1,500 hospital mergers in this country. And then if you look from 2018 to 2023, there were actually 428 hospital and health system mergers. And there have been multiple different academic studies by health economists looking at the effects of various sets of these types of mergers based on what they could get in their sample. Those find that these hospital mergers raise prices by 5 percentage points. Now, what I did with my other collaborators at the Baker Institute, we published a paper last year that found that the cumulative increase in hospital prices between 2006 and 2023 was 189%. And you can compare that to the increase in physician prices over that same time period, and also the increase in the prices of health insurance netting out the underlying increase in the medical services. So just, the increases in the costs of everything a health insurance company does in terms of underwriting and processing claims and things like that. And those price increases were 140% for physicians, 134% for insurance. So you compare that 140 and 134 to the 189% increase in hospital prices, and you can see that it's the hospital sector that is much more responsible for these increases in spending.
And Vivian, is it room charges? Is it procedure charges? Medicines? Devices? What's responsible primarily?
Yeah, that's an excellent question. And that's part of this price transparency. It's not just room charges, and it's other things. For example, with my research team, we published a previous price showing there's dramatic increases in the costs of visiting an emergency room. So emergency room prices, but it's surgical procedures, you name it, it's all going up.
Now, Vivian, there is a certain ease in comparison in this sector because an MRI of a particular kind is an MRI of a particular kind, and you can see how much the charges are for that MRI procedure across a range of places. If you do that, what do you find in terms of variance?
There have been health economists who have focused on specific procedures like that, and MRIs in particular, and they find incredible variation. You can have the price of an MRI vary by a factor of 3 across different hospitals. It's striking.
And we're speaking of within a small geographic area.
Oh, yeah. Very good point. Within any given city, you can find prices that vary 2 to 3 times.
For the same procedure.
Let me give you an anecdote of something that happened to me recently. So several years ago, I had a rare form of cancer, parotid cancer. And so my doctor wants me to come back every year and get a chest x-ray. So he told me this for the first time. So I decided to go to the hospital system where he's at. So he just sends me the referral and I go get the chest x-ray and I get a bill for $900. And I thought, wow. And so this year I said, I am not going back there. And so I get on my insurer's website and I start looking and I can find the providers in the network, but there is nowhere on my insurer's website that I can get the prices. Fortunately, from my own research, I have access to the prices. And the same x-ray, full cost, $90-something, my copay, $6. Okay, so that's the variation in prices, and that's what consumers need access to. And as an insured person from our insurer at Rice, I still can't get that on my insurer's website.
Vivian, some years, decades ago, there was a move away from inpatient care to more and more outpatient care, the intent being to minimize those room charges and all the other things that came with residency in a hospital for a patient. Didn't it work, or have hospitals adjusted their costs to compensate?
Okay, so this is a good point. Yes, if you do something on an outpatient basis, the price should be cheaper, as you pointed out. What is happening now is that under Medicare, the regulations are such that if a hospital acquires an outpatient facility, a clinic in a strip mall, they're allowed to charge not just the price for the procedure, but they are also allowed to charge something called a facility fee. And there's a great deal of discussion about facility fees. The Arnold Foundation has talked about this, a number of other different organizations. The problem is these facility fees, which on average, from what I understand, can add on $400 to your visit to your doctor. if the hospital owns a physician practice, that is actually encouraging the consolidation. There's actually an incentive for hospitals to acquire physician practices in these clinics out in the suburbs just so they can charge the facility fee in addition to the regular cost of an outpatient care.
Vivian, with these increases proceeding at the rate that they are, what does this look like in terms of costing for Americans who are grappling with the issue of do they go to a doctor, do they have a procedure done or not?
Well, it's an incredible burden on your average American household that's just trying to get by, also in the face of the inflation that we're facing. So there's a recent Peterson Kaiser Family Foundation report that found that 20 million people, 1 in 12 adults, owes at least $250 in medical debt. So that may not sound so bad. But 6% owe more than $1,000 in medical debt and 1% owe more than $10,000. And there's been other polling that shows that people with medical debt report they have to cut spending on other things, food, clothing, household items. They're borrowing money from friends and family members and they're taking on extra medical debt. There are actually credit card companies that specialize in issuing credit cards to patients at hospitals who have been told that they have to pay hospital bills that they can't afford.
So, 2 executive orders from 2 different presidents trying to crack down on the opacity in hospital pricing. It hasn't worked. Have the hospitals simply refused to submit the data? Has the data not been accurate? What's the issue?
So when you look at the Center for Medicare and Medicaid Services webpage, they will say that a large portion of hospitals are compliant. The problem is when a researcher or anyone else, a patient, goes to try and download those files and make use of them, they just aren't useful. There are rows and rows of data that actually don't have prices. There are multiple cases where they report the price over and over again for a diagnostic test or a saline bag or something like that, but there aren't the prices for the services that you would care about, the most common services. For example, I need to go get an MRI. How much does that cost? In most cases, you can't find that on the hospital posted files.
What's to be done? Is this a local legislative issue here in Texas? Is it a national legislative issue? How do we address the problem?
Well, for example, Texas did try to do something about getting hospital prices posted. And even though the legislature passed rules, they were not enforced. And it's the same thing. There are executive orders, but at the federal level, CMS needs to enforce what has been passed. So at the moment, they have fined, I think, maybe a dozen different hospitals. But of those dozen, that's a very small proportion of the ones who really aren't posting clear, useful prices. And the fines that they are imposing aren't actually for the full number of days in which these hospitals are out of compliance.
Broadly speaking, local level, state level, national, is this a bipartisan concern?
Actually, I think it is. I think you have everybody in this country. You could say, let's just forget about our political differences in other areas. Do you want to lower costs for patients? And everybody agrees that that is something they want to do. The challenge is that the American Hospital Association is a very strong lobbying force in D.C., and they are trying to tell a story that they need to cover extraordinary costs. Of course, hospitals saved us during the COVID-19 pandemic. And we've got all these Medicaid and Medicare patients, and we're not covering our costs for these patients. And so we need to charge these higher prices to everybody who's privately insured. The problem is we now have a dichotomy in our country of smaller independent hospitals that are continuing to struggle, and they do take care, particularly in rural areas, a large number of Medicare and Medicaid patients. The problem is in the cities, we have large consolidated systems that are charging prices that are well above their costs, earning high profits, and there is room to ease the burden on the middle class and make healthcare more affordable.
What happened to alternate healthcare models such as HMOs, which were so popular 20, 30 years ago, Do they still exist? Are they still a more affordable option?
We still have HMOs. For example, here at Rice, that's one of our options under our insurer to purchase an HMO package. But even the HMO option has become more expensive, much more expensive than it used to be. And so the issue is, and it's because of the underlying prices, including hospital care, solving this problem, getting these prices to become transparent is not the entire solution. We do need to get employers to be much more active in how they shop for health insurance. We do need them to get smarter because there are layers of brokers and other different parties, pharmacy benefit managers, who hold on to a lot of the data. In a lot of cases, they have constructed extremely complex contracts. You have an HR office, even in the very best firms, it's got many challenges. It's trying to deal with hiring and firing and all sorts of difficult employee problems. And then they're being asked to be very shrewd shoppers for a very complex product. And there are, unfortunately, ways in which brokers and other consultants are taking advantage of that situation and hiding in all sorts of increases in prices that you have to be very smart. You really need to get your legal team in the company on top of it in order to get a fairly priced contract.
Medicare, Medicaid. A great deal of claims are flying around now about widespread fraud within the system's need for fundamental reforms. Is there a question here of fraud, or is it the nature of this profit-making cycle which has moved now to levels that have exceeded the ability of individuals to pay?
That's a very important question, very hard to answer. There has always been fraud in Medicaid and Medicare when you have this ability to submit claims, and it's difficult to monitor such a large program. The overwhelming majority of care that is paid for at the federal state level is not fraud. It's a significant fraction, but my guess is it's well under 5% of all the payments. So you do need to address that particular issue. But there are many ways. For example, I sat on the board of Community Health Choice, which was Harris County's managed care organization, and I would see the information about the level of auditing that the state does. And each state is very careful about the amount of auditing they do to make sure that there is little fraud as possible.
The executive order that President Trump signed in February, is this going to work? Do you think that this will be enough to rectify the transparency or opacity concern that you've identified?
I would love it if it works. He's already issued a previous executive order that got the providers to post their prices, but the problem is the prices are still not useful enough. So the key is whether, he's ordered the Treasury Department, Department of Labor, Health and Human Services. The key is whether CMS actually tries to enforce and sit down with these prices. And that was the point of the issue brief that we've done. We sat down and we said, let's try and compare the prices of the 3 or 4 major hospitals within the Texas Medical Center. And we literally could not. No one should be looking at the average prices across these systems, because when we looked at the hospital stays, we could compare prices for 11 different types of hospital stays. When CMS reimburses for 700, and then for the procedures, I think there's well over 8,000 different types of procedures that can be reimbursed.
So Vivian, you've hit on something here. There are many parts of this problem, but is one of them CMS and the scrutiny and discipline it applies?
Absolutely. They just need to sit down and really try and say, don't just look on a website and say, I see a file there. The requirement is you post a machine-readable file with prices. You don't just sit there and open it up and say, I see multiple different lines of data, so we're fine. You actually sit down and say, let's try and see if we can look up the MRI.
As a consumer would.
Yeah,
Put
as
yourself
a consumer,
in a consumer's
or
place.
I'm looking at the machine-readable files, which are for purchasers. So an employer who wants to say, which hospital should I include in my network? That just can't be done right now with these hospital files.
We've built up over many, many years a huge bureaucracy around healthcare. And CMS is only one of those pieces of a bureaucracy. Is there a fundamental reform, as opposed to improvement of practices, a fundamental restructuring of, at least at the federal level, the healthcare structures? Or can this be fixed without that type of major undertaking?
There are multiple different steps we could take to make things, to reduce the waste, reduce the administrative burden. For example, when a provider fills out a claim to get reimbursed by Medicare, everything is standardized. There's a standardized form. Whereas if you're trying to submit the reimbursement for commercial insurance, every health insurance company has their own form. And of course, that's meant to slow down the process, so it's harder for a provider to get reimbursed. We could standardize those forms. There's so many complaints about denials of health care. We could actually standardize that. Texas actually came up with good legislation to come up with something called a gold card. So if you looked at physicians who in the past had very low rates of inappropriate care, that they would be issued a gold card. And so that if patients want to have particular procedures for these physicians, it doesn't automatically get denied. And those are types of things that we could do. And we could set requirements that every insurer has to have these following different attributes. And that would probably lower some of the administrative costs.
I'm going to ask you, Vivian, a very difficult question. There's a marketplace here, and a commodity is being offered. Healthcare, however you want to define that. And with some exceptions, notable exceptions, those in this marketplace are there to make a profit and to make as much money at providing the commodities that they do as they can. Yet it's people's lives, not their investment accounts, that are at risk here. Is there a role here, a very different kind of role for the federal government that has not been put into place in the past in terms of setting boundaries, in terms of charges, services, profit levels? It's a tough one. It's a very sensitive issue.
Yeah, it's a very sensitive issue, and a lot of people are going to respond, this is why we should have universal health care. They're going to say, let's just get rid of the entire private sector in healthcare and move to the government being the one reimbursement source for all healthcare in this country. We could have a whole nother podcast on why I don't think Americans actually are ready for that, which is why I don't spend a lot of time dwelling on it. I do think the current way that we've set up the incentive is we have to get smarter, because currently it is more profitable for large companies, for example, United Healthcare, to make more money gaming the system than competing and providing higher quality services and products. And we have to get smarter on how we design those incentives. I've always been puzzled on why CMS doesn't have more economists. I go to professional meetings and I'll meet health economists from other branches of the federal government, but I'll never meet them from CMS. Although my understanding is the Trump administration is actually working to create a chief economist position, which is a new position. If we can get smarter on how we design these incentives, I think we can move towards a better system.
On that somewhat hopeful note, Vivian, thank you. And I do want to come back in the future to another discussion of the Affordable Care Act, alternatives, Medicaid expansion, the aging U.S. population, and the very different and complex burden that imposes upon healthcare provision for another discussion. But thank you very much. Baker Briefing is brought to you by the Baker Institute for Public Policy, which provides meaningful, nonpartisan policy analysis on the most critical challenges facing the United States, Texas, and the world. This episode was produced by Karina Zamel with support from Grayson Beaubien. AV production was led by Kevin Young. To read our reports on hospital price transparency, you can click on the links in the show notes. Be sure to visit us at bakerinstitute.org to learn more. Thank you for listening.